Gomez, the Executive Director at the Integrated Midwives Association of the Philippines, or IMAP, a local partner organization working to strengthen the private sector. Ms. Pat will provide a 10-minute presentation of IMAP's role in supporting private sector participation in the provision of the family planning services. Lastly, we are joined by Jane Wickstrom, a Senior Technical Advisor for Family Planning and Reproductive Health on the Service Delivery Improvement Private Sector team at USAID. Jane provides technical leadership and support to country partners to advance proven and emerging health practices with the goal of scaling up high-quality integrated family planning reproductive health services. And with that, I will now hand it over to Jane to provide her opening remarks.
Thank you so much, Ty, and it's a pleasure to be here with everyone today. Thanks to everyone who's joined us, and I think you're going to be very happy that you did. Today, we're going to hear from colleagues working and partnering with Momentum. This is Momentum Private Healthcare Delivery, one of 6 awards funded by USAID at the global level to holistically improve maternal, newborn, and child health services, and of course, voluntary family planning in our partner countries around the world. Momentum, we call it Private Healthcare Delivery, but MPHD for short, really works to harness the private sector's potential to deliver high quality, evidence-based healthcare. Over the past 3 years of this project, we've worked hand in hand with the private sector in many countries to design and deliver effective and sustainable solutions that arise in a number of countries that block equal access to family planning, including in the Philippines. A large focus for Momentum's work is on strengthening the capacity of private health sector providers. And this is in line with USAID's localization strategy. We work on both the clinical side, but also the organizational capacity strengthening side to improve the market, frankly, having private providers and private associations like the Integrated Midwives Association of the Philippines, or IMAP, to navigate the barriers to wider availability of high quality family planning services with a wide method mix, frankly, and to engage with the public sector in various initiatives such as the one we're going to hear today from the Philippines, which focuses on public purchasing schemes. So again, in line with USAID's locally led development, this project supports groups like IMAP in developing and implementing sustainable solutions that are co-created. This is really a public-private partnership. We are grateful to be joined by the Executive Director of IMAP, Ms. Patricia Gomez, who will speak to the organization's experiences driving private provider participation in local government-supported healthcare provider networks. And you're really going to hear a lot about these networks and how they work today with the PhilHealth system. So I'm really excited to hear from all of our colleagues in the Philippines and to learn more about these healthcare provider networks and how they really are working in the public purchasing sphere in the Philippines healthcare system. We're going to see some challenges, we're going to see some opportunities, and really how it's grown over the past couple of years. This is for everyone's lessons learned. We're hoping as a global project that the lessons we learn through Momentum and IMAP and its partners, Think Well, that this could be really an example for other mixed healthcare systems. So for that, thank you very much for your time. And I'm going to pass it off to Dr. Jello from ThinkWell, who will speak about this work under MPHD. Dr. Jello, it's up to you.
Thank you very much, Jane and Dai, and to USAID and PSI for this opportunity to share our experience of employing human-centered design to strengthen the participation of private providers in the delivery of FP services within mixed health system in the Philippines. Next slide, please. For today's presentation, we will take you through a brief background of the FP context in the country and locally, highlighting the gaps as well as opportunities for private sector engagement. From this, we will proceed to highlight our human-centered design approach towards unlocking private sector solutions in addressing FP challenges in rural Philippines. And here, we'll also introduce you to our partner IMAP, who has been instrumental in implementing our innovative approaches. And throughout the presentation, we hope to highlight our key insights on project implementation, including some wider implications to mainstreaming private sector engagement for improved FP service delivery in other markets and in similar contexts. Next slide, please. The Philippines has actually made significant progress in expanding access to FP services in recent years. But as you can see in Figure 1, coverage remains low by regional standards. Across the country, FP provision is also skewed towards short-acting reversible methods, and this limits contraceptive options, especially among the poor and in the country's many rural areas. There are also stark inequities in access to FP along socioeconomic lines. The actual number of children per woman compared to the desired number of children is higher among the poor compared to the well-off. Next slide. Now, in terms of service provision, private providers dominate the Philippine health system, comprising 65% of all health providers. Despite this, however, private providers are significantly underutilized in the delivery of FP services, as high out-of-pocket fees place these providers out of reach of many users, especially the poor. Less than 20% of LARCs and injectables are delivered by the private sector, despite higher rates of private sector delivery of other health services. Even fewer, less than 20% in 2018, are those private providers accredited to provide FP services under PhilHealth, the National Health Insurance Scheme, which provides free or highly subsidized FP services to the Philippine population. Now, FP reimbursements from PhilHealth ideally offers an opportunity for the private sector to fill in service delivery gaps. However, ThinkWell study in 2018 identified reasons why private providers hesitate to provide PhilHealth's FP packages. Reasons include complex, confusing, and costly accreditation requirements, discouragement from delayed provider payments, and perceptions of low profitability at current package rates. Next slide, please. Now, when we started this 3-year project in 2021, there were a couple of things that really stood out as opportunities and which got us excited about this work. First, the Philippines had just introduced a novel legal framework, which is the Universal Healthcare Law, or UHC law, and which explicitly encouraged the public health system to engage with private sector providers to address gaps in health service delivery, including for FP. Now, we'll talk a bit about the law in the next slide. Second, we have observed strong leadership from provincial governments, which stepped forward to act as demonstration sites or sandboxes to help the country in implementing its intended UHC reforms. And for this project, we focused on 2 such provinces. Both are rural and both are economically disadvantaged, and we'll introduce them as well in a bit more detail shortly. Now, as mentioned earlier, the country's Universal Healthcare Law, or UHC law, was passed in 2019, and it creates opportunities. If we can move on to the next slide. Now, the UHC law, as I was saying, creates opportunities to increase access to FP services and to reduce out-of-pocket fees by engaging private FP providers to participate in what we'd call healthcare provider networks, or HCPNs. HCPNs are led and financed by the public sector at the provincial level and are meant to offer people-centered and comprehensive care in an integrated and coordinated manner. That being said, in 2021, the guidance and mechanisms needed by provincial governments for including private providers in HCPNs were unclear and have not been operationalized. Many provinces were left thinking, how do we even begin to engage private providers? This was a challenge across the country. But with the mandate from the UHC law, coupled with funding from USAID, we saw an opportunity that the project leveraged to test out and pilot whether private providers can indeed be strategically engaged in HCPNs in rural contexts to deliver quality FP services along public providers and to address unmet need for FP while contributing to the achievement of UHC goals. Next slide, please. So our project focused on improving FP service delivery in two specific provinces that Thinkwell was already working with, the provinces of Antique and Guimaras in the Western Visayas region of the Philippines. Like many other rural provinces in the country, unmet need for FP is high in both provinces, and access to FP services is limited. A 2021 Thinkwell study identifies persisting challenges, namely limited availability of commodities, especially in rural areas, the lack of trained FP providers, insufficient public sector budgets for FP, and just the fact that public health services in these areas are overburdened and overwhelmed from providing other services than FP, a situation that was made more acute by the COVID-19 pandemic. But because of excellent local leadership, these provinces have also been selected to establish and pilot the HCPN model at the earliest opportunity. The provinces of Antique and Guimaras are both rural, with high rates of poverty and real geographical and financial barriers to accessing FP services. And cognizant of these unique contexts, we therefore spent the first year of the project diving into that context and building relationships in order to determine the best way forward and before charting any concrete steps moving forward. Next slide, please. So just to summarize what we've been discussing so far, first, we demonstrated the low coverage and high unmet need for FP, especially in rural Philippines. Secondly, we highlighted that the private sector has a significant market presence in the country and that the proposed HCPNs offer a potential and clear pathway to leveraging that untapped potential to deliver FP services and increase access. However, these HCPNs have been difficult to operationalize by rural provincial governments. In light of these challenges, we first set out to understand the barriers facing private sector participation in these HCPNs, and then use that information to design solutions that can contribute to the end goal of improving coverage of FP services, including through the private sector. Next slide, please. We knew in 2021 that there were no concrete and clear implementing mechanisms for engaging the private sector in HCPNs. And as such, the project implemented a human-centered design or HCD approach throughout the year. Human-centered design is a problem-solving technique that puts users at the center of the development process, delivering solutions which are tailored to users' needs. In our case, the end users were both the provincial governments managing these HCPNs and the private providers being invited to participate in these HCPNs. We made sure to assess their needs through our listen phase. Our HCD approach also highlighted the value of co-creation. In this case, connecting public and private sectors in the two provinces to co-design solutions for private sector engagement, and then piloting and formalizing these developed solutions through public-private partnerships. And as we proceed with our third year of the project this 2023, we are now keen on empowering local stakeholders to sustain best practices for improved service delivery. Next slide. So as mentioned, we started this project with a formal listening phase. This was a really important aspect of our work. It helped to build relationships with local stakeholders and to deeply understand the situation and the nature of the barriers preventing private providers from being effectively integrated within mixed health systems. We completed a comprehensive policy review, and locally, key informant interviews allowed us to listen to both public and private sector stakeholders as to how ready and willing they may be to engage each other in a public-private HCPN. Next slide, please. From our listen phase formative research, we identified a range of sector-specific and cross-cutting challenges. On the public sector end, there was very little technical know-how, limited prior experience, and unavailable staff to deliberately pursue private sector engagement strategies. Furthermore, the prevailing sentiment in the public sector was such that engaging private providers wasn't seen as that much of a priority at the outset. And this was coupled with fears that allocating limited public resources to the private sector could risk depriving and outcompeting public sector providers. Now, among private providers, several constraints were also noted to discourage their participation in these mixed HCPNs. It was just too complex and costly for them to be trained and accredited by PhilHealth. Payments were often delayed, inculcating distrust, and that it was just too difficult to access and provide contraceptives in their rural context, especially long-acting reversible contraceptives, or LARCs. Between public and private FP providers, the two-way referral mechanisms were nearly non-existent. No one was referring to each other. And when they happened, they were poorly coordinated and monitored with limited data sharing. Most of all, we learned that the private sector was not formally organized. This made it operationally difficult for provincial governments to contract individual small private providers with a wide range of concerns and interests. These key challenges allowed us to clarify and crystallize a set of user needs, and then use these insights to design solutions in response to those needs, following the HCD approach. First, we knew we needed to cultivate trust between and among public and private stakeholders. By building trust, we could set the ground for mobilizing both sectors to work together in addressing shared challenges and co-developing solutions. Secondly, we needed to build capacity for provincial governments to pursue private sector engagement, but also foundational FP training for private providers to be accredited by PhilHealth and to formally participate in these HCPNs. And lastly, we needed to provide tools. We heard from both sides that practical operational guidance, whether it be through standard operating procedures or contracting templates, were not in place to support the full operationalization of the HCPNs. We wanted to address this through co-design, but then also provide capacity building on how to use these tools. Next slide, please. Now, within the country's mixed health system, it emerges as absolutely critical to harmonize interests and systems of both public and private sectors so that they can interact seamlessly. One way to enable this process of harmonization is to introduce intermediaries to serve as bridges. Intermediaries are locally embedded organizations that operate in the space between institutions or sectors and help link them together. And with the new partner initiative funding under MPHD, the project sought to identify and capacitate a local organization, IMAP, as a partner and as an intermediary for first engaging, negotiating, and sustaining FP service delivery partnerships, coordinating mechanisms, and shared outcomes between public and private sectors. And secondly, encouraging and organizing and capacitating private FP providers to participate in these mixed HCPNs. To elaborate further on our partnership with IMAP in facilitating the strategic engagement and capacity building of local private FP providers in the mixed HCPNs of 2 rural provinces in the Philippines, I now turn you over to our partner, Ms. Patricia Gomez. Ms. Pat?
Yes, thank you so much, Dr. Jello. Good day to each and everyone. As introduced earlier, I'm Patricia Gomez, the Executive Director of the Integrated Midwives Association of the Philippines, a non-stock, non-profit, non-governmental, or national organization for registered midwives in the Philippines, both in public and in private sector. We have a membership of more than 130,000 midwives across the country, organized among our 8 regional and 34 local chapters, including an active chapters in Antique and Guimaras, our project sites. Over the past decade and across the country, we have also been recognized as preferred training provider for family planning, counseling, and administration of contraceptives such as IUD and subdermal implants. Furthermore, as the country-only accredited professional organization for midwives, IMAP holds both the legitimacy and leverage in effectively engaging both the public and the private sector from the national to the local level. Next slide, please. In this project, we saw that one of our critical roles was first strongly advocate for private sector engagement, as mentioned, of course, by Dr. Jello, and send solidarity in the rollout of the HCPN. In the 2 provinces and in other areas of the Philippines, public and private sector often do not see eye to eye and often do not find themselves at the same discussion table. In partnership with ThinkWell, we will work towards facilitating partnership and negotiation meetings between the public and the private sector from national to local and our partner private providers. Our outreach initiatives were a golden opportunity for us to accomplish 2 goals. First is to make it clear that our public sector partners and the private sector engagement for EPI has been done before, and there's no need to start from scratch. And where it was succeeded, it was actually brought significant benefits, of course, to both private and public sector. In IMAP, we have demonstrated this proof concept in Bohol province, where private midwives were linked with provincial governments for integrated service delivery, and of course, of reporting. We have also piloted private referral engagement, of course, for agreement for private and maternal care between the private providers and public referral hospitals in Metro Manila. Our message to the provincial government was clear that private sector engagement in HCPN, as mentioned earlier, can be done and should be done, and therefore we are truly serious about improving family planning outcomes in this context. Secondly, this outreach initiative were taken as an opportunity to actually bring public and private sector in these 2 provinces together, to sit down, to collaborate towards designing solution for private providers to be engaged, of course, in HCPN. In partnership with ThinkWell, we facilitated design thinking, as mentioned also again earlier, workshop with both provincial authorities and private providers that directly address the pain points discussed, of course, by Dr. Jello. From clear and mutually beneficial arrangement, both public and private providers, to ways of sharing information and resources between the 2 sectors. I believe Dr. Jello will discuss this in further detail in a bit, but to make sure that these agreements are followed through, IMAP also negotiated and saw the approval and institutionalization of public-private arrangement or agreement by the Provincial Authority of Antique and Guimaras. We also co-hosted a learning forum to advocate for PSE to other provinces in the region last October 2022. And since then, we have received strong interest from other provinces within and beyond the region to replicate our approach to mainstreaming private sector engagement. We put a quote here from a provincial FP authority in Antique, which highlights just one example of the positive impact this outreach work had. Before this initiative, we were even thinking of engaging private providers, but we were really convinced by the IMAP that formalizing the inclusion of private partnership for family planning will not only be beneficial to the province, to the provincial health system, but especially, of course, for our clients. Next slide, please. Our second critical role in this project was to build the capacities of the private providers to participate, of course, in the healthcare providers network, informed by learning needs assessment, We did jointly with ThinkWell, we developed and adapted our modules on family planning clinical training to ensure the quality delivery of the family planning services. As an accredited training provider, this training also enabled IMAP to issue the necessary certification that will allow trained private providers to be accredited by PhilHealth, thereby formalizing their engagement with the healthcare providers network. However, participating in the HEPN takes more than just knowing how to insert an IOD or subdermal implant. It also requires being knowledgeable of the shared system and processes that allow public and private providers to work harmoniously together within an integrated network. To this end, we supplemented the clinical skills training with administrative and operational training, which allowed private providers to be trained in integrated family planning service, delivery reporting, integrated referral monitoring and reporting, and of course, joint FP demand forecasting. On a personal note, the entire process of developing and deploying this capacity building interventions was undeniably a moment of growth for us at IMAP. For the longest time, IMAP has been the preferred training organization for family planning clinical skills training. And with this project, we're seeing ourselves as being the prime mover of capacity building for our private provider participation in the UHC, as mentioned also on the universal healthcare reforms. Next slide, please. Lastly, our third role in this project brings us to the work of organizing the private providers in these two provinces into a supportive community of practice. Traditionally, private providers operate independently from each other, and collaboration between private providers was never really something that was seen as valuable. But the COPs, or community of practice, was established, played a really important role in facilitating the positive outcomes we saw and continue to see from this project, including acting as a unified voice for the private sector providers when engaging the public sector, creating an environment for knowledge sharing and peer support between different providers, supporting the pooling of resources and capabilities across providers. We highlight an example of this from Provincial, a private midwife and family planning manager, of course, in the province of Antique. An important thread which runs through all of these activities is that the COP, or community of practice, fostered opportunities to build and cultivate trust between the private providers in both provinces, but then also too between the private sector providers and the public sector counterparts. I am also happy to say that over the course of project implementation, we've seen this COP naturally organize themselves into a well-structured groups, referring to themselves as private partners for family planning, or private partners for family planning. And to this day, these PP4P groups continue to support each other, learn from each other, and rally together towards proactively advocating for private sector participation, not only in the delivery of family planning services, but also in taking part in a much larger UHC, or universal healthcare reforms. Thank you so much. Back to you, Dr. Jello.
Thank you very much, Ms. Pat. And as mentioned by our IMAP partners, the human-centered design workshops brought together the public and private sectors in the two provinces to co-create solutions that will facilitate the integration of private FP providers into the HCPNs. The concrete design product of the design thinking workshops was a memorandum of agreement, or MOA, between provincial governments, private providers, and PhilHealth, what we'd locally refer to as the Public-Private Purchaser Partnership Agreement, or 4Ps. The 4Ps agreement was the first of its kind in the Philippines, in that it set out to clarify and concretize the institutional accountabilities and arrangements by which provincial governments and PhilHealth can contract private providers to provide FP services within HCPNs, how public providers can refer patients to their private counterparts, and value propositions to ensure that such implementation arrangements are sustained and embraced by all parties involved. True to HCB principles, the 4-piece MOA was designed to be a win-win-win agreement. It's a win for private providers in that it guarantees predictable provider payments within a month, as well as assistance from provincial governments to ensure that private providers minimize rejection of PhilHealth claims. It also extended opportunities for private providers to access free or subsidized trainings that have been traditionally offered only to public providers, as well as access to publicly procured FP commodities. Private sector access to these free public sector commodities not only improves the capacity of private providers to deliver quality FP services, but also contributes significantly to the level of net income they can generate from providing such services. On the public sector side, the 4-piece agreement was also presented a win as it will enable service delivery data from the private sector to be submitted and incorporated within provincial health information systems. This stands to significantly increase the reporting of FP service delivery accomplishments and to have a more comprehensive FP service delivery data to inform decision-making and program planning. In fact, in Guimaras, the 4-piece MOA also enabled the public sector to significantly offload its overburdened public facilities by completely outsourcing the delivery of FP services to the private sector, allowing public facilities to refocus its limited resources to the many other public health programs that devolved health systems in the Philippines have to implement. Lastly, and I think this is the most important one, the MOA is a win for patients, especially for poor women. An important component of the agreement is that publicly referred and indigent patients will be subjected to PhilHealth's no balance billing policy, even if they seek care from a private provider. This policy ensures that women, even if they seek care from the private sector, will not have to shell out additional costs. And so far, the Philippines has only succeeded in implementing these among public facilities and not private providers. Next slide, please. And ever since the formalization of the 4-piece MOA in October of 2022, the project has harvested some preliminary and encouraging results that demonstrate a successful proof of concept. First, we have seen a significant increase in the number of private providers in the 2 provinces that have been accredited by PhilHealth to provide FP services. From 5 private providers capable of providing IUD services to 20, or a 4-fold increase by the end of 2022 and increasing. And from 2 to 27, or 13 times more private providers accredited to provide subdermal implants. As we entered project year 3 in 2023, we have seen our participating private providers significantly increase their delivery of FP services to as much as 30 patients in a week in one of our facilities in Antique. This demonstrates a significant win indeed, especially for our patients, now that they have more expanded options as to where they can easily access quality FP and affordable services within their context. Next slide, please. And now, as we move towards the next slide, please. And now, as we move towards the 3rd year of implementation of the project, we are seeing how local stakeholders have also begun sustaining and localizing the initiatives piloted in the project. And in fact, some of our partner private providers are here, and we truly appreciate their presence, cognizant of the fact that they have limited internet connectivity within their rural context. And our private provider COPs, the PP4FP groups, they routinely meet with each other and interface with provincial governments, identifying opportunities for joint demand generation for FP and other collaborative projects, among others. Both PP4FP groups are also working towards organizing themselves as a self-sustaining and officially accredited organization by their respective provinces. Provincial governments, on the other hand, have also opened windows of opportunities for private providers to not only act as participants in HCPNs, but also take part in a much larger role when it comes to policy and decision-making processes by providing them representation in HCPN management committees. And with the commitment and continued partnership with IMAP, we are working towards exploring how the model can be tested and piloted in other provinces in the Philippines, starting in areas where IMAP has active local chapters. Next slide, please. And I think as we end our presentation, this is our last slide. We would like to leave you with some key lessons from the project, lessons that may present wider implications for accelerating private sector engagement in FP service delivery, not only in other areas in the Philippines, but in similar contexts and markets. First is to highlight the advantages of employing human-centered design, not only in terms of allowing local stakeholders, both public and private sectors, to have a shared understanding of the challenges they face, but also in providing a well-defined process of developing win-win-win solutions together. Unique to this project is the application of HCD in developing operational guidance that translate policy to practice. SOPs, contracts, and implementing mechanisms often tend to be developed top-down, but HCD provides a bottom-up approach to ensure that such implementing mechanisms are responsive to user needs, contextualized to their realities, and can be sustained moving forward. Secondly, we highlight the power of organizing. In our case, organizing the private sector into communities of practice. Especially in light of health sector reform, organizing a community of private providers allows for solidarity building and shared learning, as mentioned by Ms. Pat earlier. And in the context of mixed health systems, COPs provide leverage in negotiating with the public sector and in efficiently mobilizing stakeholders in all sectors. And lastly, we appreciate the value of partnering with local intermediaries. We recognize the asset that comes with locally embedded organizations like IMAP in bridging the divide between public and private sectors, in using their social capital to mobilize, organize, and bring together various stakeholders, and ultimately in sustaining and mainstreaming best practices towards bringing impact well beyond our projects. And I think that's it for our presentation. Maraming salamat po and a good day to everyone. Back to you, Jane and Dai.
Great. Thank you, Jello and Ms. Pat. Thank you for the very interesting and an insightful presentations. Great. So with the remainder of our time, we would like to move into our fireside chat, and where I would ask both a few questions, and then I would also like to encourage the participants to share your questions and comment in the chat or Q&A so that we can answer as much as possible. So maybe first I would like to ask Jello and also Ms. Pat about the sustainability of all these interventions that we have used for this program. What do you foresee as the potential challenges for the sustaining private sector engagement in these through these human-centered designs interventions and then also these programs? And then how could these kind of like sustainability challenge can be mitigated, or what have you already done in order to ensure that the some degree of the sustainability would be there? Thanks.
Thank you very much, Dai. And I think that's a very important question. And with much guidance from PSI, sustainability and transition planning was actually considered even at the outset of implementing this project. We are currently in the process of co-creating a sustainability and transition plan with our local partners, both in the public and private sector. But answering your question, Dai, one critical challenge for ensuring the sustainability of our efforts is really public sector readiness when it comes to pursuing private sector engagement strategies. Most of our efforts have admittedly been focused on capacitating the private sector when it comes to their participation in these mixed health system mechanisms or HCPNs. But at the same time, this should be met by readiness and capacity of public sector authorities, provincial governments in the case of Philippines, to manage and strategically engage private providers for continued service delivery and to ensure quality. A very clear challenge that we recognized earlier on, and this is the fate of many foreign assisted projects, is that after the foreign partner has left the project site, most of the efforts are usually not sustained. And I think this is the power of really working with a local intermediary or a locally embedded organization. This provides you an opportunity to actually handhold and transfer some of the technology as well as the coordinating and organizing responsibilities to these local intermediaries so that they can sustain best practices moving forward and even after the project has ended.
Great. Miss